thank you for the invitation to come to London and to have a chance to talk to representatives, organizations, and yourselves during this last day and a half. While I have had a strong interest in subtypes, and over kind of a taping that we did yesterday, I made the comment that if this illness was cancer or heart disease, we certainly wouldn't think that everybody would be diagnosed similarly with cancer and treated similarly with different types of cancer. And I ultimately think that subtypes will occur in this field. However, even before one deals with the issue of the different distinct types of ME/CFS that might occur, there are certain types of scientific issues that need to be considered. And what I would like to do is review briefly some of the important questions that need to occur as one moves this field forward. What I would like to also present is some new data concerning how one goes about developing case definitions and diagnostic criteria. I think these are fundamental questions of science, and I think they have the possibility of moving our field even further. Over breakfast, we also had a chance to talk about, or in the discussion, think about the issues of where is our field today. And Thomas Kuhn, who wrote The Structure of Scientific Revolutions, some of you might be familiar with his important contributions to science. He's an historian of science. Really would probably, if they looked at this field, would say that we are in what's called a pre-paradigmatic era, that we have different paradigms that are, in a sense, vying for which one best explains the data. And paradigms change over time, according to Kuhn, and basically one needs to sometimes differentiate the truth from approaches toward understanding the truth, and that there's a tremendous amount of ideological issues that are involved in making these decisions as to which paradigm you particularly subscribe to. What's important is that kind of over time, things occur to a paradigm or a pre-paradigm that make people either believe in it more strongly, or anomalies occur and the anomalies can't be answered, such that people begin to move toward a different way of looking at a phenomena. In this case, we could say ME/CFS. But a paradigm, importantly, helps us think about what are the important questions to ask and what are the devices one uses, the techniques, the methods to answer those questions. So the issue of paradigms is really critically important to this field because I think, as you probably all recognize, we have individuals who represent very different philosophical ways of thinking about what patients have and how they should be treated. And these really do, I think, rest on the Kuhnian notion of paradigms. And I think, as I will talk today about some of the more specific methods that we go about in trying to understand what we think is the truth, but recognize that that truth is always changing and that we're always trying to think about new ways to guide us toward understanding that. I have been particularly interested in issues of assessment, and I think whether one is thinking about subtypes or thinking about an entity like ME/CFS, one has to be concerned about how one assesses these issues. There are, again, the specific pieces that help us understand kind of these larger paradigms. So when one thinks about diagnostic unreliability, which I might mention I think has occurred with the area that we are in, there are disagreements that occur among scientists regarding diagnostic decisions. And it's not just, of course, diagnostic decisions, but those decisions have tremendous implications for, in a sense, kind of how ultimately patients are treated. if I could kind of make the argument in a little bit less technical terms, you know, we're going to talk about some fancy language up here, but kind of for those of you who are not that interested in unreliability or validity issues, I can tell you that they're really at the core of some of the basic problems we have in this field. And to give you kind of an analogy, think about a house of cards, and think about, you know, you've got to have a stable first platform, and then you put a second platform on top of those house of cards, and a third. But if that foundation of cards is not put together correctly, or at least as well as one can, and I'm going to claim here with some issues of reliability, then everything that's built on top of that is suspect. And when I say those things that are built up on top of that, if your diagnostics and your case definitions have fundamental problems with them, ultimately, the types of individuals who you include or don't include in categories, the types of issues of prevalence, which I've had a strong interest in, how many people have this illness versus those people who don't have this, issues of treatment, you know, are you treating people who have this illness versus don't have this illness? All those types of critical decisions that you and I think about in this field ultimately come back to these paradigms that we have, and one way of understanding the paradigmatic influences is these issues of unreliability in diagnostic decisions or in case definitions. So the people who do work on diagnostic unreliability have basically said that things like subject, occasion, and information variance in making decisions really account for a small portion in other fields of diagnostic reliability problems. So I'm not going to discuss those variance issues, but I am going to be talking about criterion variance, because in a variety of fields, criterion variance accounts for the largest source of what we think of as diagnostic unreliability. So what does that mean, criterion variance? It's kind of a complicated term, but the way one thinks about it is what are the formal inclusion and exclusion criteria to classify patients into a category? So to say it a different way, how do you make decisions that a person has the symptoms that basically would have the label, for example, of ME/CFS? Criterion variance occurs when operationally explicit criteria do not exist for those diagnostic categories. So in a sense, have you operationally made those explicit criteria public in a way that does not have variance issues? And that's the task of all science. It's not the task of people who are researchers in this field. It's the task of people who do research in every field. So what I'm talking about is really kind of generic. And I want to take those themes of science and bring them to the particular interest that we have here in ME/CFS. What are the consequences of failures to have these tasks taken care of? And the assumption that I'm making in this presentation is that we have had significant problems, significant failures in addressing some of these issues in our field, particularly acute early on in the field, but they're continuing with us today. And my entire presentation is going to be talking about those differences of ways of looking at the world and how failures to think about these criterion variances and the differences in them have had influence on the types of things that occur in our field. Because, again, I'm just going to keep coming back to this again and again, that if you have categories that lack reliability and accuracy, your validity, that is, are you really studying what you say you're studying, that usefulness of the diagnostic category will be inherently limited to the extent that one does not have that basic question of reliability answered. In addition to having these types of formal criteria adequately specified, which again in our area has sometimes not occurred, and I'll get into more detail about that as we go, the second requirement for reliability is the provision of operationally explicit objective criteria. So one needs to have the objective criteria. One needs to basically say, okay, post-exertional malaise, for example, is something that we want to measure. Okay, so that's basically trying to specify there's a symptom or there's a construct. Some people would think of it as a hypothetical construct, but that we have something that's explicit that we want to measure. The problem is, how do you measure it? And if you don't have an interview, a structured way of asking the questions or of measuring, then you're going to have, again, reliability problems. So what I'm talking about has to do with some self-report issues. You can ask a person whether they've had, for example, post-exertional malaise, and depending on how you ask the question, with a sample of people who have this particular syndrome, you can get 100% of them to say yes, or you can get 50% of them to say yes. So if you have different questions that elicits different ways of people responding, then you have major problems in what we call reliability. And that's exactly what has occurred in this area. So you might kind of say, well, that's self-report data. You know, so what? I mean, we're not as interested. Well, I happen to be very interested in that data. But you could say biological data is different. You know, biological data really doesn't have this problem. Well, the reality is, if you have not specified in exacting detail how that data is collected, how it's processed, how it's stored, how it's analyzed, if you don't have explicit rules on all those particular issues, which I might add has not occurred in this field, then you have the same problems of unreliability that I'm talking about. Now, we can take one example, the DSM, Diagnostic Statistical Manual, as a lesson as to kind of what occurred, because I'm in psychology. I've had to deal with this DSM through much of my career. And what they did over a period of time from the early 1950s to the present was that they had successive changes in this particular way of collecting data. And initially, they did not have explicit objective criteria. Initially, they did not have standardized interviews. But when they basically began to work on this over a 50-year period of basically improving these particular issues, clinical diagnoses for a number of conditions improved dramatically. Now, I'm not going to go through a whole history of the DSM, but I use it as one example, and I could use other fields as well as examples of how to make changes. The key thing I want to emphasize is that change doesn't occur with one task force. It doesn't occur with one revision. Change is an ongoing process of basically having hypothetical constructs, collecting data, and then making changes, and having individuals constantly making things better. That's the way science works, and that's the way it needs to work in this area. So what I'm going to suggest is that some of the issues that I'll be talking about today and some of the problems that I'm going to illustrate need to have this type of close examination that has occurred in different scientific arenas. What is our challenge? The criteria used to define ME/CFS must be clearly operationalized. So if the focus is on the presentation of symptoms with no regard given to the antecedents or consequences of the symptoms, and again, let me just emphasize that one needs to be thinking about antecedents and consequences as well as the way in which one collects that data. The view of the patient can then become incredibly restricted, and additional sources of important information tend to be ignored. Now, again, I know I'm talking somewhat in abstract terms, but let me give a very concrete example of it. and again, suggest why this is such a critical issue. Take the issue of depression. Take two samples, one that has clinically depression, one that has ME/CFS. Basically ask the two groups, are you depressed? Yes, no. You will not get any significant difference between those two groups. They will both indicate that they are overwhelmingly depressed, that both groups have yes/no questions. Yes, they have depression. Now, ask that a slightly different way. Ask the severity, okay? So a depressed group and a group that has ME/CFS, ask basically an issue of fatigue, okay? If you ask the two groups, do you have fatigue? And I'm sorry, when I kind of said depression, I meant fatigue. If you ask the two groups if you have fatigue, the group that has depression will basically say they have fatigue. The group that has ME/CFS will say they have fatigue. They will both not be able to be distinguished with a yes or no question on fatigue. However, if you then ask the question with severity of fatigue, and you basically make that change in terms of looking at an intensity issue with a scale that isn't binary, you will then be able to differentiate the two groups. So the way you ask the question is critically important. But remember, the Fukuda criteria, which we'll be talking about later, basically has yes/no responses to the major symptoms. And that's one of the problems with it. So it's not only having the symptoms identified, but it's also critically important to decide how you're going to basically collect that information, for example, on fatigue with the depressed group and an ME/CFS group. Additional issues to be considered. There's also high variability in symptom severity, which we just talked about with depression. And we need to employ standardized procedures for determining whether or not a particular symptom is severe enough to qualify as the occurrence. And as I've mentioned, this has often not occurred and needs to occur in our area. Okay, a final consideration is the polythetic criteria. This is a set of criteria in which not all the criteria need to be present to make a diagnosis. I will claim that this use of a polythetic criteria, often derived by an expert committee, had occurred with the case definition, both of the 1988 and 1994 criteria. This might not be the most methodologically sound way of basically developing a case definition. What are some problems of that type of polythetic criteria? So a polythetic criteria doesn't specify you have to have these particular symptoms. It basically says you need to have a certain number out of a larger group, okay? So you might have two groups of patients within the same diagnostic category. You might have similar groups in different diagnostic categories. The major problem is, and I'm going to be arguing as we go on, that it's very possible that you might not identify the patients who have the specific illness. You might actually be identifying people with another illness based on these criteria. Finally, kind of words. Words that we use and how they basically define kind of the issues we're interested in. The Eskimos, for example, have multiple words to describe snow. There's drifting snow, sugar snow, salt-like snow, very soft snow, hard crusty snow, glazed snow and a thaw, snow patch. Well, there's actually other kind of terms too. You know, we have the word fatigue, and we basically think that the word fatigue is really transmitting information to others. I think we all recognize that when patients with ME/CFS use the word fatigue, they're using it in a fundamentally different way than the general population that has an experience of illness is using the word fatigue. I might add that the term chronic fatigue syndrome also connotes certain meaning, as we know. And you know, again, the vast majority of patient groups have felt that term tends to trivialize the illness that they have. But let's just kind of take the word fatigue. Our group in Chicago has recently come up with these 5 ways of thinking about fatigue, which what's most interesting is how these five, and certainly there are other terms that could be used as well, how these terms are so different in groups of people with ME/CFS versus groups of people who have no ME/CFS. So let me go through these five terms that we're using. There's post-exertional fatigue, feeling extreme weakness, discomfort, or sick after minimal amounts of activity. You don't see this in healthy individuals. It's very distinct. Wired fatigue. I mean, if you go up to someone and say, "Are you wired?" People will say, "What are you talking about?" They won't get it. But I could basically ask any of you out here, have you felt overstimulated with extremely low energy? That's classic. But again, it's not going to be understood by someone outside of our orbit. Brain fog fatigue, mental impairment with confusion, disorientation, inability to function in daily activities. I mean, how many healthy, normal people wake up in the morning, get in the car, drive somewhere, and then forget where they're going? I mean, basically the types of extreme brain fog fatigue just doesn't occur in the extremes for what people often have with this illness. Flu-like fatigue. Now, there's one that the normal population understands. Flu. They get the flu and they feel fatigued and they get over it. And because they get the flu and they feel lousy for a day or two and they get over it, they look at you and they say, "Come on, get over it. Why haven't you? Why are you still sick? I don't feel great all the time. I work. I keep going." And that's the type of problem. It's that lack of communications we often have with other individuals because their experience of this term fatigue is so fundamentally different from a patient with ME/CFS. Energy fatigues is an interesting one because it's kind of a different way of thinking about fatigue, feeling heavy, immobilized, without energy to do anything for long periods of time. In a sense, that's really one of the classic issues with ME/CFS. It's not necessarily fatigue, really. There's actually quite a few people who have ME/CFS that feel no fatigue. You probably recognize that, or at least at times. What they have is no stamina. They've got no ability to do things because once they start doing things, they basically have that crash. So the reality is fatigue is such an interesting word, and yet it has to be differentiated into all its subtypes and different elements. So in psychology, we do these fancy things called factor analysis, and it's interesting. In our samples of hundreds of people, they don't experience, healthy people, these different types of fatigue. They have one type of fatigue, the flu fatigue. That's what they relate to. That's what they have. But when you go into an ME/CFS group, what you will get, and this is kind of sort of a fancy way of saying what I'm going to just tell you, is it's a factor analysis, and you actually get nice factors in all these different areas. These are called factors, and it really comes up very nicely. So it's always, when you have theory that works out with the data, you actually end up with these things being experienced by samples that have ME/CFS, not by samples who are healthy. Very interesting. Okay, let's go back to this issue of kind of criterion variance. In the early to mid-1990s, we had what's called a non-empirical case definition that was developed in the United States. Unfortunately, from my perspective, this was arrived at by a group of people sitting around the table. And again, there's nothing wrong with theory developing kind of a case definition, but it's much better if you have data that not only helps think about what the categories should be, but also operationalize it in an instrument that allows you to capture it so that people in different settings are able to capture the data in similar ways. Neither of those things occurred when the 1994 criteria were developed. And of course, much more serious, the latter issue. And again, let me just kind of keep going back to saying why this is important. if you ultimately have data collected by investigators in different parts of the world, and they are bringing in people who differ, the samples differ in those different areas, ultimately, those individuals will have different biological markers. What will happen then when you don't have consistency in the biological markers, rather than thinking, well, there's different types and subtypes, what ultimately gets concluded is there is no biological marker for this illness. The next conclusion that occurs is that because it's not a biological illness, it must be a psychogenic illness. So the consequences of these variance issues and criterion variance problems are enormous for the science in this particular area. So let me go, and again, I'm sure that you're all aware of this particular case definition by Fukuda in 1994 in the US. They call it an international case definition, and patients are required to experience chronic fatigue of a new or definite onset. They really never well defined what that meant, which is a problem. Not substantially alleviated by rest. That was really a fascinating one. How many people do you know with ME/CFS who don't substantially feel better with rest? Not the result of ongoing exertion, and produces significant reductions in occupational, social, or personal activities. So just think about 100 people trying to define what significant reduction is, and all 100 people using a different way to make that decision. Well, ultimately, you're going to get completely different ways of deciding whether a person has that particular issue or not if you don't operationalize it. In addition, one needs to have 4 out of 8 symptoms. Now, this was, I think, one of the most interesting decisions made by the Fukuda criteria is that, yeah, these symptoms, you need 4. So if you get 4 in this area, sore throat, cervical, muscle pain, joint pain, headaches, but what happens if you don't have these 3 classic symptoms? Well, according to Fukuda criteria, you do not have to have unrefreshing sleep. You do not have to have post-exertional malaise. You do not have to have these cognitive problems. Now tell me, do you really think a person with ME/CFS does not have any of these 3 symptoms and you could classify them as having ME/CFS? Well, according to the Fukuda criteria, you can, and that's the problem. These are classic symptoms of this syndrome. Classic. They've got to be there. And if they're not there in some form, you really wonder what they might have. And that's what unreliability is about. So let me give a real concrete example of what a problem could occur in this area. A person with major depressive disorder could be diagnosed with chronic fatigue syndrome. And why is this important? Because major depressive disorder is one of the most common psychiatric problems affecting Great Britain, United States, and societies around the world. Very interesting. Almost 2.5%, approximately 2.5%, have a current major depressive disorder in Western civilizations. Isn't that interesting, 2.5%? We'll get back to this. What do you think the new prevalence data that the CDC has basically been talking about? Wouldn't it be interesting if I told you it was about 2.5%? Very interesting, isn't it? What am I talking about? Depression often involves chronic fatigue and 4 minor symptoms. Well, think about these symptoms. These symptoms are common in major depressive disorder. People with major depressive disorder have fatigue. It's a different type of fatigue, but it's fatigue. And they often have somatic complaints. So if you are not careful in using these criteria, you will ultimately bring in samples of individuals with major depressive disorder. It's not to say that they aren't sick, they are. But do they have ME/CFS? Probably not. And that's why these criteria become so important in terms of who is being brought into your samples and what types of conclusions you're making with those individuals. Our group in Chicago a couple years ago did a fancy what's called discriminant function analysis And what that involves is trying to look at predictors of things that could differentiate groups. And we actually got two groups, a group that had CFS, ME-CFS, and a group that had major depressive disorders. And we were able to make 100% distinction between the two groups if you had a wide variety of measures that weren't always reflective within Fukuda. And again, the key issue is not the occurrence of symptoms. This really has to do with severity. That means it's a continuum. And the high severe differentiates. The occurrence, yes, no, does not. Okay? But let me just kind of indicate a couple things that are important. Severity of self-reproach. People with ME-CFS do not have self-reproach. They don't have negative dialogue about themselves. Okay? People with ME-CFS do not have that. People with depression do. If you go up to a person with major depressive disorder and say to them, tell me, if you were well tomorrow, what would you do? You know what they would say? I'm not sure. Now, go up to a person with ME-CFS and basically say, if you were well tomorrow, what would you do? And they'll start writing lists. It's a different phenomena. It's different types. That needs to be understood. And if you're not a careful researcher or clinician, you can bring these two groups together. The consequences of bringing these two groups together is disastrous. That's an interesting one, shortness of breath. Shortness of breath really is talking about kind of some cardiovascular issues. You've all heard of orthostatic intolerance. You know, but it's interesting. Why isn't any of that stuff on the Fukuda criteria? Because they didn't start out at the beginning with a list and try to then say who has it, who doesn't have it. They basically preordained that these were the symptoms of importance. And that's a problem for science, because when we had a list, we were able to get this one. Now, it's very interesting that these other three, isn't that interesting? The classic three symptoms come up as discriminators. Post-exertional malaise, unrefreshing sleep, the cognitive problems, those will discriminate these two groups. But if you don't have people, based on your definition, that have these problems, of course you won't discriminate them. We've recently published an article where we actually took a series of criteria and symptoms. And isn't it interesting? We did, again, what's called a factor analysis. We came up with 6 factors. And again, some of the classic symptoms are here. But what's interesting is that we actually came up with 2 factors with a sample who had ME-CFS, who actually had vascular items, which is, again, what we've been just talking about, like dizzy after standing, and inflammation items, like chemical sensitivities. So if you really have a broader range of symptoms to start with and then see what these individuals have, what clusters together, you actually come up with new arenas. That's what's necessary for the practice of science, to don't come into an area with a restriction on the number of areas that of interest, but a wide variety, and see what the data show you. That's the way we should be thinking about classification and case definitions. Now, the Canadian criteria, which some of you are aware of, did a very different approach for trying to classify ME-CFS. They said you had to have post-exertional malaise, you had to have unrefreshing sleep, you had to have neurocognitive memory concentration type problems, and they said you had to have at least one symptom from 2 of the following categories: autonomic manifestations like lightheadedness, neuroendocrine manifestations like feeling fever, or immune manifestations like recurrent sore throats. So they specified, not saying you basically pick some symptoms, but they said these are classic symptoms, you've got to have them. A very different way of thinking about a case definition. I think it's fascinating that in 2004, our group actually compared the Fukuda criteria with the Canadian criteria with a sample, different samples, and we found that it selected cases, the Canadian with less psychiatric comorbidity, more physical functional impairment, more fatigue weakness, more neuropsychiatric and neurological symptoms. To me, that wasn't that surprising that we would find differences and that the Canadian criteria would ultimately get a sicker group. They specified the critical symptoms. The thing that's so interesting to me, remember we talk about paradigms, is why in the last number of years since the Canadian criteria were published, why is this the only study that's actually compared these two criteria? That's interesting. Well, I want to kind of talk about a very exciting new pediatric case definition that we're going to be kind of talking about some ways of collecting data that's very different from what I've been talking about up till now. An international working group from the International Association of CFS ME, and by the way, this is an international organization. There's membership forms downstairs in case anyone's interested in becoming a member of this group. And our next conference is going to be in the wonderful Reno. You'll hear more about Reno, Nevada today in May of 2009. I certainly hope many of you might be able to make that trip to that conference. The last one in Fort Lauderdale was very successful. But this working group worked on this. We identified experts. What's different about this is that, number one, isn't it interesting? You had an adult case definition that's been used with kids, and everybody said that's okay. Well, that's not okay. Kids don't have the same exact symptoms. Kids have different ways of expressing those symptoms. So why are we using an adult case definition of Fukuda, in most cases, for almost all the work we've done with pediatric samples? Totally inappropriate. This working group not only developed symptoms that were required for people to have to be classified, but it also developed instruments to measure those symptoms. And it took the third step, which is also interesting. It basically collected data to find out whether those particular hypothetical constructs were actually realized in practice. Again, those are the steps of science that are required for diagnostic instruments to be developed, for your concepts to be validated. This is what science is about. Real quickly, I want to go over what the different categories are that we have come up with. You can have severe ME/CFS. This is the pediatric case definition, and that requires all of these 6 symptoms: unexplained persistent relapsing fatigue, post-exertional malaise, unrefreshing disturbance of sleep, pain, which could be joint, abdominal, or head pain. Interesting, abdominal. 2 or more neurocognitive manifestations, and at least 1 symptom from 2 of these subcategories. Does that sound interesting or similar to the Canadian criteria? We lifted that template from the Canadian criteria, but we sensitized it to a pediatric sample. So a severe case of this would have all of these. And it's not just having it, but it's having at a certain frequency and severity, operationally defined. So again, it's specific. It's got an instrument to measure these symptoms, and it's got criteria to decide whether you have it or don't have it. It's all operationally defined. That's what's needed. And I might add that the questionnaire that we use is on the CFS ME website. So any of you want to use this instrument, it's free to everybody. And the criteria that we've developed are also free. Now, a person could not have all the symptoms. They might have what we call moderate. And they don't meet the strictest research criteria. They might have 5 out of 6 of those symptoms. So we found a number of people who are very sick that they just missed one of those symptoms. So we basically created a moderate category for them based on the data. In addition, there's subtypes. We have basically ME/CFS-like. By the way, these symptoms don't involve 6 months or more. These symptoms involve 3 months or more. Again, a critical difference. But some kids have been sick for 1 month or 2 months. So we don't want to say they don't have anything. So we might say they have ME/CFS-like. Okay? So that could be that's something that they develop maybe after having 3 months of symptoms. But there also, we found atypical cases where they basically had only 2 or 3 classic symptoms. and they're really very sick, but they don't have, for example, all the symptoms. So they might just have post-exertional malaise, memory concentration problems, and be bedridden. Well, do we basically say because that child has not experienced any pain or unrefreshing sleep, we're not going to allow that child to be in there? We're going to call them atypical. Interesting cases. They might not meet the full criteria, but they're atypical. And we also have a category in remission for children who once met criteria but no longer do, operationally defined by what it means. Now, we have recently, and this study actually hasn't even been submitted for, or it actually was just submitted for publication, so you're the first people to hear about this study. So we use what's called ROCs, receiver operating characteristics, to look at issues. This is what epidemiologists do. We kind of invent very large words so no one understands what the hell we're talking about. No, not really. But we have these two terms called specificity and sensitivity. And we looked at the two criteria, and we said, okay, you've got the Fukuda adult criteria, you've got the pediatric new case definition, and you've got a group of people that we had referred to us from very, very skilled physicians who treat pediatric ME/CFS. And it's very interesting that using the Fukuda criteria, we actually had very significant problems with sensitivity. 24% of the patients with ME/CFS were missed. In other words, the physicians referred them in. And basically the Fukuda criteria said they didn't have the illness. Fascinating. Whereas in this case, there was only one case in the pediatric, and this was a child who was in remission. Very close, but we couldn't classify them according to our criteria. So what that suggests is that we need to be looking at ways of contrasting and comparing these case definitions. And this is an example of where we had a group of people, came up with criteria, we basically operationalized it with an instrument, we collected data, and then the data helped us think about making changes in our criteria that reflected what the instrument should be measuring. And then we basically tested that instrument with the other criteria to see which one had more what's called sensitivity and specificity. And we found that the pediatric case definition was more effective. And we hope that it begins to be used by people internationally. Now, I want to contrast that with what's called the new Empirical CDC CFS case definition that Bill Reeves has recently announced. And I want to show you how a different way of approaching some of these issues. And you might not have heard much about this case definition, but I think it has significant importance because the CDC is a very powerful organization in the United States, and what the CDC does often influences researchers around the world. So we should know when the CDC comes up with a new way of diagnosing patients, in this case adults. According to the new Empirical CDC CFS case definition, patients are identified by meeting criteria on 3 standardized instruments, measuring symptoms, disability, and fatigue. Let's go through each of those areas because I want us all to dissect specifically what is going on with this new case definition in a way that allows us all to become scientists, again, with our own biases. Okay, let's look at symptoms. You have to have certain symptoms. Again, using the Fukuda 8 critical symptoms, you basically have them measured on perceived frequency, from going from 1 a little of the time to 4 all of the time, to severity. Now, again, recognize you don't need to have those 8 symptoms. You can have a person, as I mentioned, who does not have post-exertional malaise, who does not have unrefreshing sleep, who does not have memory and concentration problems, and they could still get enough of these perceived frequency and severity. And what happens is you multiply the frequency times severity, and you have to get a score of 25. And if you get a score of 25, you meet criteria. So let's kind of take a look at one particular child or one particular person. 25 would be reached if you had 1 symptom, muscle pain, occurred all the time, severe intensity. That's 16 of the 25 points by one symptom. And then if you had one symptom, sore throat, occurred some of the time, moderately, get a 5. And then 2 symptoms, headaches and unrefreshing sleep, some of the time in mild, to get another 4. So this person would meet criteria, just to give you what it might look like operationalized. Clearly, there are some people who have symptoms that are much more severe than this who are not going to be missed. But clearly, it's going to pick up quite a few people who might have kind of borderline symptoms. Time frame for the critical symptoms. The CDC Empirical Case Definition has symptoms based on the last month. Well, they've now changed protocol. The Fukuda criteria said the concurrent occurrence of 4 or more symptoms in all must be persistent or recurrent during 6 or more months of the illness. So they've changed it from 6 months to the last month. Now, why is that important? Because some people do have these very common symptoms for several weeks. But do they have it for 6 months? That's the key question for adults. And again, I claim that this is a major change in the case definition that most people don't know about. Criteria for the new empirical CDC case definition, disability. Now, okay, you could sort of say, well, they got symptoms, maybe they made that decision. Interesting, how they ended up with 25. That's an interesting question. But this is even more interesting. How do they measure disability? Okay, they have a thing called the Medical Outcomes Survey, short form 36. It's called the SF-36. And good, they're using a standardized instrument. It's used to assess substantial reductions in occupational, educational, social, recreational activities. You know, I'm part of the Chronic Fatigue Syndrome Advisory Committee that's appointed by Secretary of Health and Human Services of the United States. And a couple weeks ago, I had a meeting. We had the meeting. And I remember I looked at Bill Reeves and I said, who sits as an ex officio officer, and I said, you know, there's some problems with this new empirical case definition. And I said, the SF-36 says, basically, if you have a score lower than 25th percentile on one or more of the following scales, but these are the 4 scales. So if you get this, that makes sense, physical functioning, disability. If you got role physical function, that makes sense. If you got social function, well, you know, now we're getting a little bit strange. But then if you get role emotional, problems with work or daily activities as a result of emotional problems, I said, Bill, role emotional, this is the key question. If you get one of these 4, you only need one of them, not all 4 of them, not 2 of them, not 3, one of them. If you get role emotional functioning, you get marked as meeting the disability criteria for CFS. Okay, you understand that? If you get role emotional, that's all you got to do. Very interesting. So I said, Bill, he's a good friend of mine. I can use Bill. So I say, Bill, you know, it's like interesting, role emotional. There's been quite a few people that have wondered why this is put on here. And, you know, because of this problem. The lower 25 percentile on this role emotional scale is less than or equal to 66.7. The key question is the mean for role emotional for a clinical depressed group was 38.9. Every clinically depressed patient will have met disability criteria for CFS based on that score. Every clinically depressed person will meet role emotional disability. Interesting. So I said to Bill, I said, you know, there really is a problem with this new empirical case definition with role emotional. And his response to me, he says, well, we came up with a working group in 2003, and you were actually an author of that, sort of saying that I kind of, in some ways, supported what he was doing, which I thought was an interesting response. But this is why it's so important to be specific. Yeah, in the 2003 paper, we said these are the measures that are appropriate to use. But he then decided with his group to operationalize them in a way that I think was a major mistake. And that's why it has to be, you've got to take all the steps. when you're basically dealing with these variability issues if you want to be successful. And you can't stop with just stipulating the ways you want to measure this thing, the instruments you want to use, but you've got to talk about the criteria and what counts. And this was, I think, a totally inappropriate decision based by the CDC. Well, let's just go to the last thing, which is multidimensional fatigue inventory. Well, you have to have fatigue. That's the third piece, symptoms, disability, and fatigue, to be classified as a person with CFS, according to Bill Reeves at the CDC. Now let's look at how fatigue is defined, meeting criteria. Again, in the details, you find what's important. And this is why I say to all of you, with your physicians, you basically come to them with details about your cases. In science, we've got to do the same. We've got to look at the specifics of how people are operationalizing exactly how they're measuring the symptoms that you have. And a failure to look at the specifics of what is occurring means that we don't understand how they're measuring your symptoms. And then you ultimately become the victims of that. They used a good instrument, the multidimensional fatigue inventory. I contacted Smets, by the way, and I asked Smets, who's kind of European, I said, do you know about this criteria, how they came up with it? Their response to me was, beats me. I said, okay. Well, what Bill Reeves and his group said was that you had to have greater or equal than 13 on a fatigue dimension, or, remember, or greater than or equal to 10 on reduced activity. Interesting. So you got one or the other, one or the other, and you meet the fatigue criteria. Well, let's kind of see how you can meet this criteria. This reduced activity criteria you would meet if a person indicated the following two items were entirely true. I get little done, and I think I do very little in a day. If you said these were true, you would basically meet the fatigue criteria, even though you might actually have no fatigue. Interesting. Did you know that? Very interesting. Well, we decided to look a little more closely at these criteria and what they mean for prevalence. In the Wichita study, which is a classic randomized study to try to find the prevalence, and this is why I'm going to emphasize why this is so important. The work that we do on these diagnostic issues has incredible importance for who has it and the groups of people who have this illness, what attributions we make about them. Let me make those 2 points, if I can. In the Wichita study, they brought back people that they had evaluated from 97 to 2000. 58 were brought back in the Wichita CDC study for an inpatient study. Now, using the classic Fukuda criteria, which has problems, but still has been used by investigators around the world, only 16 had a diagnosis of CFS. So using the traditional method, 16. I might add, which is pretty interesting, 6 of those 16 had been diagnosed with major depressive disorder with melancholic features, which, by all accounts that Bill Reeves has supported, should have been excluded. But let's not even talk about that minor problem. Let's say there's 16 people with basically CFS according to the traditional way of thinking about whether the person meets the criteria. Well, with this new CFS empiric sounds very official, doesn't it? Like it's like science and they can't be wrong. 43 people were diagnosed with CFS, the same group. So again, let's just think about this. The same group, 16 were diagnosed using the traditional way, 43 were diagnosed using the empiric way. Thus, the new empiric case definition criteria have incredible implications for estimates of prevalence, which will probably increase. The estimates of prevalence have now increased. The U.S. government has basically said that the prevalence, according to their estimates, has gone from about 400,000 people to 4 million or more people. It's interesting, in the early 90s, there were less than 20,000 people. So you kind of wonder. We've really gone lots of different ways with the CDC in terms of how many people they think have this particular illness. There's a number of activists who feel very passionate about us supporting these new numbers of 4 million. And because what it does is it creates the image that there's more people affected. But let me make sure you all understand this. Think about 100 people that you know. Think about 100 people that you know. Do you think 2.5 of them, 2.5 out of 100 people you know, have this illness? That's what the estimates are suggesting. Now, 2.5 people among your orbit probably have fatigue that's serious, probably caused by many things. 2.5 people in your orbit probably do have major depressive disorder, but do they have ME/CFS? That's the question I'll ask you. Think about. But what are some of the implications? Let's move to something besides prevalence, because this might have something that touches more. We just finished a study, and this is, again, something that we presented at the International Association of CFS ME in Fort Lauderdale, where we took 2 groups of people, one with CFS and one with major depressive disorder. We gave the classic symptoms of measures of symptoms, disability, and fatigue that I just went through, and it's very interesting. We found that, yes, in our 100%, the group with ME/CFS, they all met criteria using these measures. But in a major depressive group, 40% met criteria. I might add, the thing that was just remarkable is that, just again, to get the clinical flavor, we had one major depressive person who on physical functioning scored 100. That means this person could run kind of a marathon and feel okay. This person did have significant emotional difficulties. This person did have a number of symptoms. But let me emphasize that what's most interesting is that this particular individual was classified as having CFS. Let me kind of make it a little bit more concrete with the implications of a case definition by a new study that was published in 2006 by Christine Heim from the group down in Georgia, where they used this new Empirical CDC Case Definition and the Wichita data that I've been talking about to explore the influence of early adverse experience on risk for developing CFS. Childhood trauma was an important risk factor, and about 63% had some type of early abuse. Well, when you have a large number of individuals that have had early childhood abuse, ultimately the investigators and others begun saying that, well, early childhood is important. Some people go beyond that and say, well, gee, maybe this is a group of people who primarily have psychogenic explanations for their illness. Well, that's one of the consequences, I think, of a broadened case definition when you have individuals in that category who might have this illness and others who might not. I might add that our group in Chicago in 2002, using a traditional system for diagnosing this illness, found the prevalence rates of sexual and physical abuse history among individuals with CFS comparable with those found in individuals with other conditions involving chronic fatigue, including medically based conditions. Relative to those with CFS who report such history, most individuals with CFS did not report interpersonal abuse. So again, depending on which case definition we use, you can have very different types of interpretations of some of the etiology of this particular disorder. Well, I've been given the card saying that I have to wrap up, and I want to be compliant with my audience and the individuals here, and respectful of the other work that you're going to be hearing. But in conclusion, and I probably will have to wait for your questions during breaks, as well as at the end of the program where the speakers will be here, and I'll be delighted to take your questions at that point. But in conclusion, what I've tried to say today is that these basic issues of science, of criterion variance, of reliability, of validity, have incredible importance for the type of work that we do as researchers. The paradigms that we subscribe to influence, focus us toward what the types of things that we study and how we study them. Those ultimately have incredible public policy implications in terms of prevalence rates, but they also have incredible implications for how you as patients are treated by your physicians. When you go into your physicians and you hear them with certain types of expectations of how many people have this illness, of what the reasons are for this illness, and how people ultimately can be treated for this illness, those types of decisions ultimately are based on the types of scientific issues and questions that I've raised. Thank you.